This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
We'll make a start for the next session. I'm Peter Hicks and I have the honour and privilege of introducing the various speakers. I'd like to congratulate you all on being here. This conference, I think, started on Thursday morning, and it normally starts on Thursday lunchtime, so we went to the nearly 2.5 days' worth of effort, so good on you for staying awake. I think this session has the most interesting title of any session. It's right up there with Dogma 8 My Homework, I think, which we did at Wellington. So congratulations to the organisers for coming up with, I think, it's going to be a really interesting session. And I think this is a cue to generally make this as informal and humorous and entertaining and informative as we can, rather than being scientifically exact, and I hope there aren't any p-values in any of the presentations. It's a great pleasure to introduce the first speaker, Jean-Daniel Chiche. I do like French, it's such a wonderful language. He is the Professeur de Réanimation à l'Hôtel Cochin à Paris, and that sounds so much nicer than saying I'm an intensive care specialist from Wellington. So, a quick Google search will find that he's on Twitter, YouTube, Facebook, LinkedIn, which I think sounds much different and much nicer in French. And there was something called Pub Facts, which I'd never heard of, but you mentioned in that as well. He's going to talk to us about clinical information systems, and I'll leave it to you. Welcome.
Thank you very much. Good morning, ladies and gentlemen, dear colleagues. It's a great pleasure to be here. It's been a great conference for me, and I really enjoy spending time with people that are so creative, nice, and warm. So the title I've been given today is Clinical Information System, and I have two slides of disclosure, one slide of disclosure. The first disclosure is I have absolutely no idea of what's going to happen tomorrow night or this night. So there will be no prognosis, and that's my real slide of disclosure. So, clinical information management system. A couple of days ago, I had the opportunity to speak about what is intensive care around the world, and I told you that to me it's very much like Formula One because it's quick, dangerous, expensive, high-tech, and it represents teamwork. And when you think about intensive care, that's what you see when you're watching TV, and you don't see this. But no one would imagine running a Formula One team without having mission control and real computer control of what's going on. And when we think about the current challenges that we are facing in the intensive care unit, one of the most significant challenges around the world is to have a very accurate evaluation of the medical condition of the patients we are treating, the interventions, and the related cost. And to me, this can very much be achieved by implementation of ICU-specific information management system. When you look at the landscape of electronic health record, and when you look at what has been implemented over the world, most of it has been implemented for billing purposes and for insurance purposes. But the real value of electronic health record systems to me is to improve the quality of care, to decrease medication errors, to improve the documentation of care, to evaluate the performance of our ICU teams, and decrease cost. And it's really interesting to see that none of these expected benefits actually depend upon technical consideration. If you look at the case for CPOE, for computer prescribing order entry systems, there are obvious benefits. But still, these data are a little old, but believe me, it didn't change that much. 60% of the hospitals were planning to implement it in 2005. 29 were actively discussing it. 20% had CPOE in selected units, and less than 2% of the ICUs were equipped. And today it's very much the same. It's roughly between 5 and 6% in overall, and in some countries you have a better penetration of this type of system. Slow changes, except again in some specific country. If you look at the richest part of Belgium, in the Flemish intensive care units in Belgium, you see that you have an increase in the percentage of units that have CPOE, but again, the number of ICUs that are fully computerized is very limited. And you may wonder, why do CIMS fail to cross the chasm? And I have one good example to tell you why it doesn't work. Think about this. A couple years ago, when Apple tried to introduce this type of thing, did not work. Technology was not ready. When technology became ready, when they moved from just another software engineer to someone that clearly understood what the customer's needs were, I can tell you that this was associated with a large increase in sales, and I don't know many people today that are not aware of this. And I would contend that introducing CIMS in the intensive care unit is not a real shock. It's not Intel inside, idiot outside, and people that have absolutely no understanding of what computer means today. I think it's very different, and our nurses, they are not afraid of technology. They are not anymore, nuns that have absolutely no clue about the way you use a computer. Even they understand, Why it doesn't work? It doesn't work because we fail to learn from the past. 70% of large projects failed because of failure to take into account the social and professional cultures of healthcare organization and failure of developers to actually learn lessons from the past. I have a very strong argument to make for CIMS in your ICUs, and I think if you want to pick a CIMS for your unit, you need to think about a computer that is ICU-specific, where all the functions are computerized so that you benefit from computers and you don't suffer from the rigidity that they have without having all the obvious benefits. You need a bottom-up approach. The ICU team need to be involved in the selection and the implementation of the system. And the number one step is to think about the care processes. If your unit is a mess, and if you introduce computers, it's going to be a computerized mess. It's not going to help you in any way. And the last point I'd like to make before I move on is that the goal of this is not to forget about the 4 core pens. It's not about just documentation. It's really implementation of a system that will help you to optimize the processes of care. Why it doesn't work? Because we don't speak the same language with the engineers. Our work is interpretative, interruptive, multitask, collaborative. Somehow it's a chaos in the unit. And the engineer, when you tell them, help us build a decision support system, they think in a totally different way. They are very objective. They think in a rationalized way. Every step of their process is very linear, normative, and so on. And in the end, they give a system, and we are unhappy with the system, and they say it doesn't work. And they say, oh, don't worry, we did not develop it right. No, you did not develop the right system. And this is where we actually fail to communicate very often. That's a non-exhaustive task list that we have to face in our ICUs. And when you look at this and compare this to what's happening in the other departments in the hospital, it's quite different because we are linked to the technology, and also because not only in terms of documentation, transmission of the information, it has to happen on a very impressive number of data points, but also the effect of what we do is sometimes measured within minutes. It's not you're increasing steroids from 0.5 to 0.6 milligram per kilogram, and you're going to see like next week whether the patient is feeling better. You have to see what's going on within a couple minutes. And that's why we have monitors in our unit, and that's why I contend that we have very specific needs. If you connect the devices that we have and connect them to the information management system, it's going to send back information that will be extremely helpful for all purposes, not only documentation, but also analysis of the care process. Basically, you want all functions to be computerized. You want ergonomy. You don't want people queuing up to have access to a computer. and you want a complete involvement of the workforce. And that's what's going to guarantee the quality of the data. You want them to be putting data in the system while they are doing their daily work, not having specific efforts to actually do it. And if you do this, you are going to reduce the time they spend on documentation. And this is one of the many studies that have shown that it's translated into improved quality of care, but most importantly into direct care, direct time spent close to the patient. On November 6, 2006, when we did put a system in my unit, the first thing that the nurses asked is, oh, we may actually need an ICE tool to actually stand close to the computer at the patient bedside because we spend more time at the bedside now than we used to do. There are many data that show us that there are medical errors in our intensive care units, and many of these medical errors can be actually improved by putting computers at the bedside. Indeed, CPOE can decrease medication error and improve patient safety. It has been shown as being a very significant problem. Drug allergy, drug interaction, prescriptions that are lost, not signed, or unreadable. A good example of this. I mean, you're a nurse. I mean, how can you make sense of this? You know, in the morning it looked fine, but by the end of the day, very difficult to know where you're standing. So the case for CPOE is obvious. There are many, many, many good reasons to do it. And it's not only about doctors and writing, but also making sure that you take care of drug interaction and context-specific drug interaction. Many papers have shown that introduction of CPOE can actually decrease the number of preventable errors, especially the number of preventable errors that are associated with increased length of stay and adverse consequences for the patients. If you look at this recent meta-analysis, you can see that most of the studies actually demonstrated a positive effect and with statistical significance, and there are only very, very few studies that have demonstrated negative effects. Interestingly, when you compare the system that were used in those units, you will realize that most of the studies that reported negative effects were studies where the CIMS in place were not ICU specific, but were rather generic for the total hospital. And that makes a big difference. When I order aminoglycosides in my unit, I'm presented a window where I know whether the patient has renal failure because I have urea and creatinine level. I know when was the last dialysis episode, and if the patient had already received amikacin, I would have the drug level that would be presented at the time that I have to actually order amikacin for that patient. That makes a very big difference as compared to a system that is not linked to your overall care documentation system and where you don't have the creatinine readily available and you don't know when the last dialysis episode was. A lot of papers have been published in this field. They show that indeed, as compared to a paper-based unit, in computer-based unit, you will decrease medication errors. And there are many meta-analyses now that have looked at this. If you look at this one, reported recently in Annals of Internal Medicine, they looked at 257 studies, coming mostly from 4 institutions only. And you can see that the 3 major benefits demonstrated were decreased medication errors, were enhanced surveillance and monitoring, and increased adherence to guideline-based care. Again, the process is, the thing is not, you don't want to replace this by something that is digital. What you really want to do is to improve the processes of care, and this is what I call truly connected care. Let me develop this. Before the implementation of CIMS, what you produce is basically paper. And while you're doing patient care, you're also trying to educate the workforce, you're also doing research, and if you introduce CIMS, what you're going to produce are data. And these data, you will be able to actually look at them, analyze them, and react on them so that you can actually modify your processes of care and make sure that you implement the best care. I've shown you this slide a couple of days ago showing you that we need to be moving toward engineering of medicine when evidence does exist and that is not implemented. There are data in the literature showing you that after implementation of a CPOE, you can improve the way you care for patients. You can improve the number of patients that are transfused inside the evidence-based indication and decrease the number of patients that are transfused outside those indications. You can also improve glucose control. I know that in this part of the world and in my part of the world, we do not believe in very tight glucose control, but we believe that we should exert some sort of glucose control. And with a clinical notification system in this CIMS, you can actually have alerts sent on the pager of the caregiver that will help them to know that indeed this patient right now has an episode of hyperglycemia or hypoglycemia. And this study elegantly demonstrated, published this year, that this type of notification system can be associated with a reduction in the number of hyperglycemic episodes and in the reduction in the number of hypoglycemic episodes. Same type of notification system can tell you that your patient is at significant risk for renal failure. And in this study, they compared the pre-implementation period, an alert period, and a post-alert period. And you can see that they were able to witness an increase in the number of therapeutic intervention with the aim to decrease the incidence of renal failure when the physician in charge was informed about a condition that would be associated with increased renal failure. We don't know how many of our patients are ventilated within the normal range for tidal volume. That can be also something you can measure with CIMS if everything is connected. Let me give you one example of improving patient safety. When we introduced M&M rounds in my unit, we realized that a lot of cardiac arrest episodes were associated with the use of non-invasive ventilation on weekends in hypoxemic patients. The Group 2 minus indication of the French Society of Intensive Care. We decided that either we forbid our residents to do this, we say that cannot be done, or we ask them to think about what they are doing. And just implementation of this small menu in the non-invasive ventilation prescription order, asking them, do you know why you are ordering this procedure? And if you're ordering this procedure for this group 2 minus indication, then it's going to be associated with arterial blood gas within 1 hour and with the nurse chasing you within 1 hour to actually reevaluate the patient condition. Then you can actually improve your patient condition. Let me move quickly through this because I'd like to spend the last 2 minutes speaking about the future. The future is now. I think that it's really time to change. We cannot accept that in our ICUs we have no system to evaluate medical condition. I'm not advocating for our ICUs to look like this in the future, but I'm really advocating for healthcare software that will take into account the fact that we need decision support at the bedside, that we need to improve patient safety, and at the same time improve workflow efficiency. And this has to take into account the fact that computers have changed and they are now part of our lifestyle. I believe that the next computer system will be really at the intersection between healthcare, information, and computer science, and we really need to be working with experts, people that have designed systems that are helpful for people and not that make people slaves. 5 reasons to develop this vision. ICU-specific systems are the future of intensive care monitoring, and they will help us to, for instance, assess whether your patient is food responsive because you're connecting the ventilator, the hemodynamic system, monitoring system, and you can actually make sense of the information that you acquire bit by bit because the computer can easily tell you that the monitoring system have detected that this patient may be food responsive. The industry is shy, but this time will come, and it will come more quickly than we think. We need to be able to share expertise across IT networks. We know that there's a need to have a more full-time equivalent. We also need that the more you do things, the better your patients will do. You can improve your expertise, sometimes sharing expertise across IT networks, and you can see in this review from in critical care medicine that you can have a decreased mortality and improved care for telemedicine for remote places, and this can be associated with specific decrease in ICU claims and in costs associated with this. I'm not advocating that you need a robot at 2 o'clock in the morning to come and look at you, but we may actually share expertise across IT networks. This will be at the center of our patient safety agenda that was already listed in the Vienna Declaration, and we believe that scientific societies have a role in boosting the advent of ICU-specific computer information management system. The European Society of Intensive Care Medicine and the ESA are working on guidelines for CIMS, ICU-specific CIMS. And this will, I think, and I'm looking at all of you that are involved in the ANZICS CTG, help us to fill ECRF much more easily and much more readily if we have all units computerized, and we'll be able to extract data that inform the way we do research. Finally, it will help us to make sense of big data analytics. We are now in the era where we are supposed to take the promises of the Human Genome Project to advancing the science of medicine and improving healthcare for everyone. And this can happen only if we can indeed involve personalized medicine and genetics into our electronic health record system. And there are consortiums looking at this. The eMERGE consortium, for instance, is really trying to integrate the huge amount of clinical data that we generate every day with the genetic data that are now coming, and that will be available in more than 10 million people within 2020. I mean, if Google invested in Google healthcare systems, that's not just by chance. And this will change the way we think about not personalized medicine, but precision medicine that's coming now in the era of big data. I told you that the future is now. I think that it's true, the future is now, but we will rely on increased collaboration with healthcare scientists and biomedical engineers, and for this we need to put one word at the center of our agenda, and this word is innovation. Thank you very much for your attention.